I do ultrasound down in the emergency department. We ultrasound all the things. I think last quarter we did about 2,000 POCUS exams. So if any of you are interested in POCUS, come find me. And I know that for the second year, Adam Rothman has a baller elective. So if you are interested in POCUS, highly recommend taking his elective. It's awesome. So let's dive into it. He asked me to talk a little bit about gallbladder and a little bit about the aorta today. So, and if at any point you have questions, throw them up in the chat and we'll see what we can do. All right, so let's get into this. All right, you see, let's see. All right, so conflicts of interest. Unfortunately, nothing to disclose. If somebody wants to start paying me for this, that would be awesome, but here we are. So just a really quick survey, looking down over in the chat. Have any of you done ultrasound at all at some point, picked up a probe, maybe? I'm getting blank stares, so maybe not, but maybe some of you have. So there's a couple different probes that you can use. Some people have said yes, awesome, in the chat, fantastic. Raj, Galit, and Lenise have done POCUS, sweet. All right, so then you guys are a little bit familiar with this. For those who are not, you have 3 different probes that we generally tend to use. You have your curvilinear, if you can see my probe marker. You have your linear. You have your phased array. For when you're using your gallbladder, really, this is the ideal one. You should be using your curvilinear probe. It is a lower frequency. The resolution isn't as awesome, but it penetrates deep enough. If you are in a pinch, you can use your phased array. That is an option, not as ideal, but great for getting through your ribs, because sometimes your curvilinear won't get through the ribs. You can do that. Unfortunately, your linear probe is kind of useless unless you are doing this on a child, which I don't know why you would be looking at a child's gallbladder, but you know, times are changing. So those are your 2. Start with your curvilinear, move to your phased array if you need to get through the ribs, but that's essentially where you need to be starting. World's fastest anatomy review, because I don't know about you guys, but anatomy was a while back, but all of you remember on the right side of the patient, you have your liver, you have your gallbladder hanging out right underneath it. The diaphragm is going to be the upper border, your gallbladder, your duodenum, your common bile duct, those are all going to, in your portal vein, those are all going to be on the lower edge. So those are some of your basic anatomy, obvious. And one of the things to keep in mind when you are looking at your patients, sometimes it's not straightforward. This isn't going to be something where you're going to be perfectly sagittal, perfectly transverse. Sometimes the gallbladder can be essentially in an oblique angle and you're going to have to adjust a little bit. The easiest way to start, and we'll go over this in a minute, is put your probe midline with your probe marker facing towards the patient's head. And then you can essentially slide down to the right under the ribs and start looking for the gallbladder that way. Another trick that one of our techs taught us that is fantastic, regardless of the size of your patient, regardless of the size of your hand, and I don't know if you guys can see me up in the corner here, take your thumb, put it under the subxiphoid process, put your pinky right under the subcostal margin. Where your middle finger is, start there. That's where the gallbladder almost always is. Doesn't matter the size of the patient, doesn't matter the size of your hand, start that way. There's a very high chance that you're going to find it that way. So what does the gallbladder actually look like on ultrasound? So we're going to show you a couple normals first. Got a lot of different anatomy going on here. So this is your liver. Here's your gallbladder just coming through. Can you guys see my marker? My little, okay, good. So just because it's a lot of anatomy you're going to be looking at over here. So here is your gallbladder coming through in the sagittal view. Here's your portal vein right there. If anybody's curious, this is the right heart, and you can actually see the IVC coming underneath. Anybody who's done their CCU rotation yet probably has looked at the IVC at some point. And right above it, CBD right there. Okay, so that is in your longitudinal, like your sagittal view. And then coming over here in your transverse view, essentially what you're going to do, once you find your sagittal view, turn 90 degrees towards the patient's right. And that will give you your transverse view. And essentially it'll look more like a circle as you're going through. So here we are just kind of scanning up and down. You want to get all the way to the neck, because if there are any stones there and they're stuck in the neck, this is where it's going to be a problem. You also have a little kidney over here with the cyst. A lot of anatomy going on, but this is probably the big one that you're looking for. So get your sagittal, get your transverse. That's half your bowel. Now, as you're going along. You are going to want to take some measurements. We tend to measure on everybody just for the sake of completeness and practice. To be perfectly honest, the more that you practice on normal, the more comfortable you will be when you see abnormal. So this is measuring the anterior wall of the gallbladder. You find your transverse. You can do this in the longitudinal also. Take your still, measure. Upper level of normal is 0.3 centimeters or 3 millimeters. That's the upper level of normal for your gallbladder wall. You also want to make sure you're measuring in the anterior edge. You don't want to measure on the posterior side. Basically what happens is your gallbladder is a cystic structure. Ultrasound beams love cystic structures. What they're going to do is it's going to come through, it's going to bounce all the way through that, and you're going to get what's called posterior acoustic enhancement. So in other words, it's going to be very bright on the edge. It's going to kind of obscure the real edge, and you might be over or under measuring. And this is why you always go on the anterior view, because you don't have to worry about that. It's kind of actually the same thing with bladder, whole different ballpark. If you want one of these days, I'll get into that too. So measure your gallbladder wall and measure your CBD. Especially even if there's no gallstones. So, and it's one of those things because a lot of times if CBD is small, people are like, I can find it. Trust me, you can find it. If you can't find it, just look for, when you're in this sagittal view, you'll see the main lobar fissure. You just follow it down, portal vein, boom, right above it, almost every time. And we'll go into the anatomy a little more around that. But the CBD, you want to find it every single time, because when you finally have somewhere where you're like, oh no, I really need to see what this CBD looks like because I'm worried about a choledocholitis. I'm worried about an ascending cholangitis. If you're not used to seeing what a regular CBD looks like, you're not going to be able to find the abnormals. Little thing to throw out there. This is just a fold. So gallbladders can be folded over. So a lot of times people will see something like this. They're like, no, septation. It's just simply flopped over on itself. And a Phrygian cap. So this is one of those things, they're fun to find. I have one. If you're ever in the ED and you're bored, I don't know why you would be, you guys are really busy, but if you're ever bored, you can feel free to scan me. I have a Phrygian cap on my gallbladder because I scan myself all the time, I get bored. Anyway, so here you are, Phrygian cap. This is a lot of things. If any of you know what the Smurfs are, Phrygian caps were actually back from, I believe, the Persian times, but the Smurfs have Phrygian caps, and this is essentially what it looks like. It's essentially just a little fold in your gallbladder, and that's normal. All right, so now we've gone over what normal looks like. Let's do some cases. So some of you, when you're on the floors, or even if you're in your clinic, I have no doubt that you are going to be seeing people with belly pain. It probably happens pretty frequently, I imagine, over at the Ryan Center or any other clinic that you're having. And we see it a lot in the ER. So you'll have your patient, for example, here's somebody, she's 40-year-old female, hyperlipidemia. She's been having this intermittent right upper quadrant pain. And after eating foods for the past 3 days, over the course of the past days become constant, no fevers, no chills, nausea, no vomiting, no diarrhea. You guys have probably seen this at least a couple times in your clinic, I have no doubt. So what are you going to do? Well, this is an ultrasound lecture, so there is only so much that I can hint towards. You are going to grab your trusty probe and you're going to go take a look at your patient. So tip-wise, in addition to going over the middle, what you can also do if you're having a hard time getting your images, turn them left lateral decubitus. So obviously in your intubated ICU patients, and you should be looking at their gallbladders too, you can't do that. But in anybody else who is able to roll over, go ahead and turn them into left lateral decubitus. What this does is it's going to roll your gallbladder forward, and it's going to make it a lot easier to see your gallbladder. So here they're kind of going through the ribs, as you can see, going through the ribs right there. But you can also go under the ribs. When you are doing this, you should also take note when you're going under the ribs if it hurts. All of you guys at some point have probably done a regular Murphy sign on somebody, but there's something called the sonographic Murphy sign. When you are reaching under the ribs and when you touch that gallbladder, if they basically yell out in pain, that is the sonographic Murphys. And that is a hint, if there's stones there plus the sonographic Murphys, you need to be thinking about cholecystitis. All right, so what does a stone in the neck look like? Here we go. All right, so here you are, a little bit of liver. Here is your gallbladder. They didn't measure it, but here is your stone. And you're going to see a little bit of shadowing behind it, and this one is stuck in the neck. If you have somebody who you're able to roll them over and that stone rolls out of the neck, it's probably not going to be a cholecystitis. You might be looking at a biliary colic. That's somebody who would just do a general surgery referral. But if it's something and they're having terrible pain and it's still stuck in the neck, feel free to send them on over to the ER or give general surgery a consult. So what you're looking at here, kind of the same idea. Here's one stuck in the neck, but we have this beautiful shadowing behind it. So what happens with your ultrasound is just like anything else, instead of where it's going behind and giving you this hyperechoic area for your posterior acoustic enhancement, when it hits a stone, obviously it can't penetrate that. So it's going to bounce right back. The top of your gallbladder, your gallstone will be very bright, but you're going to have shadowing behind it. And that's just simply because it cannot pass through the stone, just like it can't pass through ribs. So they did a little measurement up here. Here's your portal vein. Here's your hepatic artery. Here's your CBD. Some people call this the Mickey Mouse sign. As Dustin, who is on this call with me, can tell you, I am not a fan of the name of that, but this is essentially your portal triad that you're going to be looking for in addition to your stones. Okay, questions so far? So far, so good. Okay. Another thing that you're going to do, as I mentioned, please measure that wall. So if you have somebody with stones, here's all your stones. You could have one big stone. Yeah, you can have a whole bunch of tiny stones. You can have a bunch of medium-sized stones. But one of the things you want to look for, in addition to your shadowing and your stones, how thick is the wall? So here we are, it's at 0.4 centimeters. That's above our cutoff of 0.3 centimeters or 3 millimeters. So that would be, as we mentioned before, that's your upper level of normal. You're also going to look for some pericholecystic fluid. We don't have that here, but if somebody like this would be worth talking to Gen Surg about. Let's go over our CBD and our portal triad a little more, because this is the one where I really do try to emphasize trying to find it. Now, as I mentioned before, and as you guys probably recall from way back in the day, you've got your portal vein, you've got your hepatic artery, and you've got your CB, common bile duct, not cannabinoids. We do see a lot of cannabinoid hyperemesis downstairs, but nope, we're talking about the CBD today. So this CBD is your common bile duct. Your hepatic artery can be underneath it. It can also be above it. So if you see it above it, don't freak out. That's just a normal variant. Another way that you can try to find, if you don't get this beautiful view like this, you take your portal vein, turn your probe until this guy is long, and then you're going to see the CBD running over the top of it. Always measure inner to inner. It's by convention. Essentially, you're trying to see if there's any kind of dilation over there. All right. So just kind of, if you guys also want, I could send you these slides. Also an option. So you can review it on your own if you wish. So liver, hepatic artery, portal vein, common bile duct. Pretty easy. Your common bile duct here is 0.6 centimeters. Not bad. Depends on the age of the patient. We'll go into that in a little bit. Whenever you have a patient who is coming in with any kind of elevated, their bilies are up, they're jaundiced, etc., you have to be thinking about your common bile duct. You can have a regular cholecystitis with no common bile duct interference, but you do need to start considering that whenever you have somebody who has any kind of jaundice. So there are some rules around this. When I mentioned earlier with this guy, when you're measuring over here, it's the anterior wall is 0.3 centimeters or 3 millimeters, the upper level of normal. CBD is a little weird. So this one is actually by age. There's a couple, and I've read a few things where some people are completely disputing the rules, but the fast and dirty way to remember it is by, it's normal up until about age 60 if it's 6 millimeters and below. Above that, you tack on per decade a millimeter. So if somebody's 70 years old and their CBD is 7 millimeters, fine. If they're 80 and it's 8 millimeters, fine. Leave them alone. It's just essentially, once you get above 60, it can dilate. If somebody has had a cholecystectomy and you're looking for their CBD, that can be up to 1 centimeter regardless of age. So that could be 10 millimeters, 1 centimeter, totally fine, not a big deal. But once you're getting above that, it's probably going to be abnormal. Here we are, very tiny. I think this is actually mine. That's your portal vein. Here is your tiny little CBD. That's your gallbladder right over there. So trust me, you guys can find it. This is one of my favorite fake outs. And one of the reasons why it's one of my favorite fake outs is because those of us who do a lot of POCUS, eventually we all get fooled by this. So we have our gallstones. This is somebody with right upper quadrant pain. You can see all our gallstones back down here. And you can see like all this, what looks like fluid around here. And it doesn't quite look right. And you're thinking, well, pericholecystic fluid, of course. But notice how this liver is like a little more uniform. It's actually a pretty fatty liver. And when you see it in the transverse, you can see that that fluid is not kind of like flowing around it. It's just kind of like in these separate areas. And this is actually something called fatty focal sparing. So don't let this fake you out for your pericholecystic fluid. Fatty focal sparing is just the way the fat globules tend to lump around and show up near the gallbladder when somebody has a fatty liver. This person still had cholecystitis, but you kind of got to look at it in the whole picture. So don't let this one fake you out. At some point, you're going to see it. Another fun thing that we sometimes see down in the ER, actually, some of you might know Eddie Dranoff. He's one of my second years, going to be a third year. He got this fantastic sludge ball. So sometimes it's not always just stones. Sometimes you can have just a solid mass of sludge. There might be stones in there. We can't see the stones at the moment, but you'll have this massive ball of sludge, and this can end up causing a certain amount of abdominal pain too. So kind of in a very brief summary, when you're thinking about your cholecystitis or any kind of pathology like that, look for your gallstones. You're looking for a thickened anterior wall, 3 millimeters or above. Look for some pericholecystic fluid, but try not to get faked out by your fatty focal sparing. Positive sonographic Murphy's sign. That's the one where when you try to go under the ribs and they scream out in pain, that is your positive sonographic Murphy's sign. All right, questions so far? Look at the chat. All right. So kind of all over the same thing again. Your patient is back, but this time, same scenario and everything, but you go to scan the gallbladder. Like, where is the gallbladder? I don't see the gallbladder. I'm scanning all over the place. Here's my liver. There's my liver, there's my kidney, but where the heck is my gallbladder? And then you see this thing over here and you see all this shadowing and all this, and you get it over in the transverse and you see all of this shadowing. This is what we call West sign. So wall echo shadow sign. So sometimes this has fooled a couple people. What ends up happening is this gallbladder is so full of stones that you can't even really see the outline of the gallbladder. So you have your wall, you have your echo, which is the bright, essentially the hyperchoic area where the beams are hitting the stones, and then nothing but shadow. So that's called wall echo shadow sign. So we'll call it West sign. So when you're looking around and this is what you see, don't worry. And this is somebody you might want to go get a radiology study if they're having right upper quadrant pain. All right, so a couple little cases. There's a couple ways to think of this. You go in to see your patient and he is very jaundiced, looking pretty yellow. And then you take a closer look at his eyes and he's actually quite yellow. So this is somebody, whenever you're seeing somebody like this, and I guarantee you guys have seen this, I've probably admitted one of them to you for an MRCP, where you can spot them across the room. They look like they've been attacked by a highlighter. So if you have a 60-year-old male, they maybe have right upper quadrant pain, maybe they're a little tachycardic, and you note this yellow. You might be thinking about a choledocholithiasis. This is somebody who's probably going to need an MRCP and an ERCP. Surgery should be involved because they might be taking out the gallbladder at the same time. Versus somebody where if they're sick, they're altered, maybe they're tender in the right upper quadrant, but they're not giving you a great history and they've got a fever, still look at the gallbladder, still an option. You might be looking at an ascending cholangitis. So keep in mind whenever you have your yellow patients that these are both options. So this is where I was kind of getting into the please, 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 please look at your common bile duct. Now this person is flipped. That's okay, not the end of the world. Got a little bit of liver going back and you can see the stones hanging out right here. And then as you're scrolling over, you see the CBD. You're like, something doesn't look like. So we go and we zoom in on that CBD and you can see there's a fantastic little stone stuck in the neck right there. And you look at these guys, you're like, well, that doesn't look right. They're both about the same size. One of them's got to be the portal vein. So how the heck do I figure out which one is that portal vein? Throw on the color, my friends. Throw on the color. So you have your color going down here. You're going to see, by the way, red and blue have nothing to do with venous and arterial. It just has to do with direction towards or away from the probe. If it's going towards the probe, it's going to be red. If it's going away from the probe, it's going to be blue. If you really want to mess with somebody, you can actually just flip it on the screen. Nothing to do with arteries and veins. Okay, just please keep that in mind because a lot of people We'll sometimes get those backwards. So you confirm here is your portal vein. So you measure your CBD right above it. Oh no, they were 40 years old and we got a CBD that's 0.85 centimeters. That's clearly too, and on top of it, they're yellow. So this is somebody who had a choledocholithiasis. Another one that we had, as you can see over here, we got oodles of stones. And so we go ahead and what we did is this time, instead of going for the main lobar fissure, like we ended up finding the portal vein, you threw a little color on it, and then you took it and you made it sideways. And so you lengthened out your portal vein, which is always fantastic to do. And you get something called double barrel sign. So in other words, like for as morbid as it is, double barrel shotgun. I'm from Pennsylvania. We go varmint hunting sometimes. And you'll have this portal vein down here, and then you have your CBD up here at the top. So the CBD being the same size as the portal vein is never going to be normal. It is never going to be normal. So when you see something like that, and you have somebody with their jaundice, you should be worrying about this. So go ahead and measure it. They might have measured a little bit over here, but you want to be inner wall to inner wall. And this is, no matter how you cut it, that is too big. All right, questions so far. So you're going to look at your CBDs, you're going to look at your walls and your transverse and your sagittal views. I think we've beaten that to death so far. So let's look at a little bit more weird stuff. Every single time, I guarantee there's probably somebody coming into the Ryan Center with abdominal pain and they are eating a cheeseburger in the waiting room. Tell me it hasn't happened, because I had somebody where I had to delay their procedural sedation because they ordered a pizza to the ER after I had to reduce their shoulder. So you have somebody, here we are, 40-year-old male, hyperlipidemia, right upper quadrant pain, and they are coming in and they are eating in the waiting room. And then you come and you see them for their right upper quadrant pain. So you go ahead and you do your right upper quadrant ultrasound, but you see this. This is why it's always important to ask when they last ate. So this is somebody who had eaten recently. You can actually see there are layers of the gallbladder wall here. This is not, there's no stones. This is simply contracted gallbladder. It's doing its job. So if you were to measure these walls, it's going to be too thick, but it's because it's contracted, because it's actually doing its job to squeeze out the bile and dissolve the fatty foods. So don't freak out when you see this. Now, if it's somebody who hasn't eaten in 24 hours and you're seeing this, something might be up. Go get a radiology study. But if anybody who ate recently, that would be a completely normal finding. The other famous fake out that has happened to all of us at some point is you see this, and it's a lot of dirty shadowing. You're like, what the heck could this be? That must be a huge stone. What's going on here? And it turns out that you have just caught an excellent section of the duodenum. So the duodenum happens to sit very near the gallbladder, and depending on just the way their anatomy is, it might be in your way. And if it's somebody who has eaten recently, or we all have air in our intestines, you might end up seeing this dirty shadowing, and that is just simply duodenum. Famous fake out. All right, so I think we're about 20 minutes in. Questions so far? I'm going to periodically check in with you guys because I know it's a lot being thrown at you. All right, so here we go. This is actually a pretty interesting case that I did have over at Luke's. 71-year-old male, diabetes. He had a cholecystectomy for classic case of cholecystitis. The problem is this happened right at the start of the pandemic and there were no ORs. So we ended up getting a percutaneous drain. This was complicated by an infection. Eventually he got bacteremia. He eventually had to get a washout. And this was like 8 months ago. Now over a year ago, but at the time it was 8 months ago when I saw him. So now he's coming back in. He had a week of actually measured fevers at home, like 100, 101. And he was coming in with this right upper quadrant pain. So whenever he's had his gallbladder out. Whenever anybody's had their gallbladder out, though, you can still get a stone stuck in the CBD. It's not that the CBD is gone. So we were kind of expecting to see this that we saw before. We went to scan him, though. That is not what we saw. So we measured the CBD. Here's your CBD. There's your portal vein. That is screamingly normal. But then we saw this over here. So left lobe of the liver, he had a giant abscess. It was probably a hematogenous spread. Maybe there was something that seeded there. Where it was, we ended up getting a CAT scan, and he ended up because of the location of it, IR could not get to it with a percutaneous drain. There was nothing for surgery to take out. So he was admitted for IV antibiotics, and he cultures grew Enterococcus. And fortunately, he ended up making a full recovery and was discharged. So yeah, but he had this multi-locule. It was a 6x4 centimeter loculated abscess. So when you're looking for your CVD and you see something like this, you're going to need some further imaging. All right. So you have your 40-year-old male with a history of alcohol abuse. They're coming in with this mid-epigastric right upper quadrant pain. This could be a lot of different things. It could be alcoholic gastritis. It could be a peptic ulcer disease. It could still be the gallbladder. It could be a hepatitis, et cetera. There's a lot of different things that would be on your differential here. So you go ahead and you take a look in the right upper quadrant, and this is one of the things you see. So what you're looking at here, here's the liver. This is a cirrhotic patient, and he has ascites all over. You can see the fluid coming up above the liver. Normally you don't see that, but a lot of times in people who are very cirrhotic and have a lot of ascites, it's actually going to go above the liver. It's no longer adhesed to the diaphragm. But one of the interesting things is this person did have gallstones, but he had an edematous liver. I'm sorry, an edematous gallbladder wall, and it had nothing to do with the cholecystitis. He actually ended up being not tender in the right upper quadrant in this case. He, just because of the amount of fluid that he had in his abdomen with the ascites, it infiltrates the gallbladder wall, and you end up with the edematous gallbladder. Whenever anybody has a fluid overloaded state, you might see this. So keep that in mind whenever you have somebody with chronic ascites. All right, so you have your ICU patient. Whenever you guys are doing an ICU rotation, keep those in mind. This was one, I think it was, I forget if this was up in the West ICU or if it was up in the, I think this was in the West ICU. There was a patient who came in and they had this very, very thick, but acalculous. There are no stones in here at all, but a very, very thickened gallbladder wall. So a lot of people, I'm going to pause this for 1 second. They're going to look at this and they're going to measure this wall, and that's incorrect. You actually have to measure all the way over here. This was a huge edematous acalculous cholecystitis. Was the original read when they did get a radiology ultrasound. Here it is in transverse. They ended up getting a HIDA scan, and there was an argument that it was actually a chronic cholecystitis. They never came to an agreement about it. It was treated with antibiotics. The pain resolved, and they were sent home. The gallbladder was not taken out, but still an interesting one that you might end up seeing in the ICU at some point. Another interesting one. So this was actually, so why would I be showing somebody who is running? I had this 38-year-old marathon runner who came in. He was just feeling short of breath, wasn't able to run how he would usually run. And he was found to be in heart failure. They never figured out why. He didn't have COVID at the time. There wasn't really a myocarditis. He did have a poor EF. He did have B-lines, which we're not going to totally go over that today. But one of the things that we ended up also finding is whenever you have like congestive heart failure, or you have anything that's causing hepatic congestion, you can also get edema of the gallbladder wall. So he actually also was having right upper quadrant pain. He had no stones at all. But in addition to the poor EF, poor ejection fraction, and the B lines, he also had this very thickened gallbladder wall with no stones. Here, 0.75, quite a bit. All right, one last random example, and then if it's all right with you guys, I will move on to our aorta. So just because this is really nifty, if you ever see this, this is really cool. If you ever see this, please send it to me, please. This is awesome. So these are Rokitansky-Aschoff sinuses that have cholesterol crystals in them. This is called adenomyomitosis. If you see this on your gallbladder ultrasound because you're worried about a right upper quadrant pain, look for something else. This is not the cause of your problem. It's not super common, but if you do see it, it's neat. Make note, take a picture, but go look for something else. This is not the cause of your problems. It's just one of those one-off things. All right. So let's see, how much time do we have? Questions before I move on to the aorta? Because I think I've got about 10 minutes left. Chat is empty, so I'm going to assume you guys are ready to rock and move on. Yes? All right, so your pearls and pitfalls. Kind of went over those, beat them to death, some references, but wait, there's more. And we're going to move on to our aorta. Okay, you guys see the word aorta over here? Yep. And you're not seeing my notes. Okay. So we went over this very briefly. I'm not going to beat it to death, but in this case, obviously the linear, unless you were doing this on a child, the linear is going to be completely useless. A lot of times your phased array is also, unless you're doing a rush exam and you don't have time to go flipping between probes. Seriously, use your curvilinear because you're actually gonna have to apply a lot of pressure to get bowel gas out of the way. World's fastest anatomy review because you guys are closer to your anatomy class than I am, but keep in mind on the left side of your patient is the aorta and on the right side of your patient is your IVC. What you're going to do is you're going to kind of start in the middle and you're going to apply pressure. So start transverse and just keep applying pressure. And you're going to keep applying pressure until it comes into view because you really got to move the gas out of the way. And don't let patient habitus be the thing that scares you off, because there's a lot of time if somebody has extra, if they have more lipids than other people, that's not an issue. That actually does work in your favor as long as they don't have gas. Gas is the enemy, air is the enemy of ultrasound. So if you can get the gas out of the way, you're great. It doesn't matter the size of your patient, but just try. So here we are, we're going to go over a little bit of the anatomy. This is actually the very proximal gallbladder. I'm sorry, aorta. We were just talking about gallbladder. This is a very proximal aorta. And what you're looking at here is what we call Siegel sign, because we've got to have a sign for everything. And we come up with some funny names, and this is a Siegel sign. So here it is, your celiac trunk. Your aorta is actually down here, and you're going to have your hepatic artery and your splenic artery coming off of it. This is kind of a tricky one to get. You really kind of have to be under the subxiphoid to get this one. If you can get it, that is awesome. But it is kind of a relative one to try to get, because sometimes you're just not going to be able to get this in your patient. You're going to have to just look at where you're at. Now, keep in mind, you're starting out transverse on your patient. Your probe marker is to the right of the patient. Now they're normal, so you scooch down probably about 1 centimeter. Sometimes I will start in the middle and I will scooch up as soon as you find it. The big thing that you want to do is you want to find your vertebral body. Because if you do have somebody who has a bigger habitus and you are not seeing the vertebral body, and you're like, for example, just seeing this, and you might be measuring this as the aorta and you're wrong. You could end up missing the entire aorta, and that can be a big issue, especially if you're looking for a AAA. So this is a case of, here is our vertebral body. Here is our IVC. Sometimes you'll see the left renal vein coming off of it. We just don't quite catch it in this view. Here is your splenic vein coming over the top. Here's your SMA. This is what we call the mantle clock sign. If you guys remember Beauty and the Beast and the one clock in Beauty and the Beast, maybe, kind of, I'm seeing some head nods. That's a mantle clock. I did not realize for a long time people didn't necessarily know what a mantle clock is. It's the little clock from Beauty and the Beast. So they call this mantle clock sign. And this is your aorta. And I said normal image, but I kind of lied because that's a great big fat dissection flap right in the middle of your aorta. The rest of it is normal though. So some actual normal images. What we do in the ER, in order for the residents to get credit, they actually have to get 5 very specific images. You guys might not have to do that. If you are doing a rush exam, you should be looking at the aorta. And if somebody is actually circling the drain in front of you, you could do something called an aortic slide, where you start and you just survey down and you just slide down and you're looking to see if there's any kind of aneurysms, and then you flip to get your longitudinal. This is when you have your crashing patients in the ICU. If you don't have that, you should try to get the different views, largely so you get practice at looking at different areas. In this case, here we have our proximal. Measure top to bottom. They're a little bit off here, but you should be top to bottom, top to bottom. It's okay if you do left to right, but you've got to have top to bottom. That's the only way it's going to count. And it should be 3 centimeters or less. So anything above 3 centimeters is concerning. Now, keep in mind, aortic root coming off the heart, that's 4 centimeters. Once you get in the abdomen, it's 3 centimeters. And once you get to your iliacs, boom, you get your 2 iliacs, it's 1.5 each. Anything above that, you need to start getting concerned. If this is somebody that you are monitoring regularly and you notice a quick change, like they went from 2 to 2.5 centimeters in a week and they're having abdominal pain, that's somebody you should be sending in for a CT. But generally 3 centimeters is our cutoff. I think mine's like around 1.5. If anybody wants to scan me, you guys are totally free to scan me. Anyway, so here you are, you go to your distal, so you get your proximal. you get your middle. So you're looking near your celiacs, you're looking near your mantle clock, and now you're going to get your distal, and then you get your iliacs. You want to get the split. What I often encourage my residents to do, just to kind of prove that we know where we are. Here is our vertebral body. Here is our IVC. And what they're doing is they're showing me the split, which is going to be right around the belly button. This might mean extra gel in the belly button. That's fine, or you need to tilt from the side. But that's essentially at the level of T10, which is right near the umbilicus. That's where it tends to split. And then you're going to go ahead and you are going to get your longitudinal view. This is actually, a lot of people skip this one. This is probably actually the most important one, largely because if there is a dissection flap, there's a high chance that this is where you're going to spot it. So like everything else, you're measuring outer to outer, okay? Not inner to inner, outer to outer. So your CBD was inner to inner, your aorta is outer to outer. And again, still got to be under 3. So sometimes you're going to be looking at it and you're going to be like, wait, is this the IVC or is this the aorta? How the heck do I know where I am? Well, if you happen to spot any branches coming off of it, that's definitely the aorta. You're also going to notice that there's thicker and you might see some of the spine underneath of it. Here's your celiac trunk coming off. Here's your SMA coming off. That is definitely the aorta. So let's look at a little pathology. If anybody has ever seen Alien or Spaceballs. So there is a couple different cases where it's going to be really obvious. Probably the entire purpose of showing this one, which is screamingly obvious, you got to make sure you got to go all the way to the edge of the aorta. Because one mistake that we will sometimes see is people will measure just the lumen and they've missed this entire thing. So if you measured from about here to here, you might say, oh, it's, you know, it's on the upper edge of normal, but it's fine. But you are missing this entire giant 6.5 centimeter with a hematoma inside of it, abdominal aortic aneurysm. Not subtle, but please make sure that you measure all the way. So if you see this, and it's somebody who's hypotensive, call surgery. This is our dissection flap again, but I'm showing you as it moves in. It's essentially as the heart's beating, you can see it moving with the blood flow. Then they went ahead and they got their sagittal view, and you can see how there's the flap coming into view across. Last case. So this is somebody who actually had a graft aneurysm around it. Throw some color on it. I'm a big fan of throwing color on stuff. Throw color on all the things. You can see that's actually like where the flow is happening, but we've got flow over here. They measured it. Couldn't quite do up and down. This is an aneurysm. And here it is on the longitudinal. You can see here's the graft coming through the aneurysm. This person actually had a leak. You need to get you're not going to necessarily see a leak on CT. I'm sorry, on ultrasound on the bedside. You might have to get a CT. So probably the biggest thing is look for your abdominal aortic aneurysms with this. Look for your dissections. But if you have somebody who you don't see the dissection, but you're really concerned about it, get the CT angio because it will help you. It's not going to rule out a dissection. If you see it, great, you've ruled it in. It is not going to rule out a dissection if you don't see it. So you got to get your CT angio. Definitely use this for your rush exams. I don't know if they've gone over the rush exam with you yet. If you have not please take Adam Rothman's elective. It is awesome. I'm going to keep shouting this from the rooftops. It's awesome. Consider throwing color on things if you're not sure what you're looking at. For example, if you're trying to see flow, if you're not sure if it's an aorta, you're not sure if it's an IVC, you can throw color on it. That's a little bit more from the scope for a very beginning lecture like this. And for your aortas, always outer edge to outer edge. All right, questions? Because that was a lot of information and a lot of pictures that just got thrown at all of you. I actually have more pictures, but I figured that I didn't want to actually smush all of you.
Thank you so much, Dr. Yatta. I had a question for the class. So do your bread and butter patients who come in with, epigastric pain or classic cholelithiasis patients, you see some stones, do they get a regular full radiology scan as well? Or do are you comfortable just diagnosing them on your POCUS and then sending them to follow up with surgery?
If it's a biliary colic and I don't see signs of cholecystitis, so for example, if somebody with known stones, their pain's under control and the wall isn't thick, I will probably actually have them follow outpatient with surgery. If it is somebody where I'm really concerned that this is stuck, et cetera, and surgery might still say like, no, we think it's a colic, and that's fine, but they've got to weigh in on that. What ends up happening in this, because for the ones that are coming in for official surgery, they do have to get in essentially a radiology study, largely because they cannot see POCUS in the OR. And there's also a certain amount of, unfortunately, we live in a litigious society. So that's one of those things where it's like they might not be super cool with that, which I understand. But if it's somebody where I am often using it to just double check, whenever I have somebody with mid-epigastric pain, or I have a right upper quadrant, even mid-epigastric pain, I'm still going to look, because it's one of those things. There's been a couple times where I've been like, oh, maybe it's their heart, and then I see that they've got a raging cholecystitis. Well, that's something to consider. So it's a fast exam. It doesn't take long. If I see a totally normal gallbladder, I'm moving on to something else. And then I could just kind of like take that off of my list. If it's something that's ragingly obvious and looks like, oh crap, they need their gallbladder out, yes, I'm going to get the radiology scan because surgery needs it for in the OR. Does that answer your question?
Yeah, so more of a rule out.
Yeah, for a lot of that, yeah. There's other things that we also look at. We didn't have time today. I also look at the kidneys. There's been a couple times I've caught some renal colic that way. You can see hydronephrosis that way. A lot of times I will go ahead and I'll take a look at the heart. Sometimes I've caught twice now we've caught a tamponade just by dumb luck with somebody. Their EKG was unchanged, their tropes were negative, and they actually were in tamponade. So I'm a little biased. I'm the ultrasound director, so I scan a lot of things, but yeah, that's how I tend to use it.
Sounds good. Any other questions from anybody else?
How often do you guys do this on the floors, specifically gallbladder? I was kind of surprised that they asked on it. I thought it was really cool that they're wanting to talk about gallbladder upstairs. I thought that was cool.
Actually, not very often. I think most of our focus is either lung or heart, and predominantly lung. But we're trying to expand more and develop a curriculum for POCUS, which which span across 2 years. So I think for that, we're trying to expand into abdomen and then also vascular, like for DVTs and things we haven't touched earlier.
Yeah, I think for like where gallbladder will really come in handy for you guys, because a lot of times like you're not seeing the cholecystitis because they're going over to surgery. I guarantee it's probably going to pop up in the Ryan Center at some point. But your ICU patients, because acalculous cholecystitis is a big reality that they have to deal with up there. And this is something you can repeat. You can do it at bedside. You don't need to be like sent, like you don't have to wait for somebody to come up and do it. Especially if it's the same person doing it over and over again, just kind of like how you guys are doing the hearts and lungs over and over and over again. When you start looking at the gallbladder, and you can monitor it essentially. So
that's exactly what we're looking for.
Cool. Probably the biggest thing I could recommend, and it really depends on you guys. We scan each other all the time. Like literally every single resident has scanned me in the EM program at some point. If you guys are comfortable with it, seriously, scan each other. Scan your partner, scan your, don't scan the dog, but you scan everything else. And because the more you look at normal, the more it's going to be easier to spot the abnormal.
We will be scanning each other very often now.
Cool. And you guys are always welcome. Like, I'm pretty sure, like, let me see. I could probably pop it. I'll just put it in the chat. If anybody does want to scan, like when you guys are down in the ER, or if you have questions, literally every single one of my residents has my number. This is my cell. Fastest way to get a hold of me are these emails. You guys are always welcome to come scan with me. No. All right.
Thank you so much for joining. It was a great lecture. Thank you.
All right, cool. Keep scanning, guys. And if you have like any feedback or other things you want to talk about, let me know. And take Adam Rothman's elective. Serious.
Thank you.